Let's see. All right, cool.
This meeting is being recorded.
Yep. So yeah, and for you guys who don't know me, I founded CodeRx, the Slack chat channel anyway, and have since gotten to know a lot of really interesting people. We invited Kent, as you mentioned, to join us. He was busy. I know he knows a lot about the space as well. But I just wanted to do and my background, just so you know, is I was in retail for 5 years. I worked Kroger and then Target. The day Target announced via like the news that CVS was acquiring all their pharmacy was the day I handed my resignation, and nothing to do with CVS specifically. I always happened to have been job seeking anyway, and that was the day that I was announcing it. But yeah, kind of a fortuitous move there. But now I am with Vanderbilt University Medical Center in the health IT department, being like an Epic analyst, do lots with data and CDS. But in my spare time, I do lots of programming and app development, and just kind of self-taught and curious about this space. And I also have kind of like started going down rabbit holes of things related to pharmacy. And they don't teach us this, at least in my pharmacy school. I went to Butler University. I don't think it's common to learn about how the pharmacy economics in the world of drug pricing really works. Or maybe I just didn't, maybe I just tuned it out. Maybe somebody mentioned it, or it's like, but and working retail also, like I always saw like the little, like, I don't know, I can't remember what it said, but it was always like usual and customary, whatever. I saw like, oh, interesting, whatever. That's really important to know as an owner, obviously, as some of you are. So I don't really have a good format for this. I've got Miro up. I was hoping to kind of just take notes as you all talked, and I can kind of help bring points forward. But like what I'm ultimately trying to do, the big picture is like, this is huge picture, but like literally what happens between point A and point B. Patient comes with a prescription, they leave with medication. Like so many things can happen, right? So like one of them is pay cash, I guess. One of them is use their insurance. One of them is go through a discount card. What am I forgetting here? I mean, we can just kind of like start doing this, like pay cash, do insurance. And insurance is insurance here and not synonymous with PBM?
Yeah, I would just use PBM instead of insurance because it's more precise.
But I'm going to put Francis PBM or PBM Francis insurance.
And also pay cash is slightly different than use discount card too, because you almost have to include use discount card as PBM involvement.
Yep.
Discount card is a subheading under PBM.
Okay, got it. Yeah, right. Pay cash, use insurance, use discount card, cost plus. Is that slightly different than all of these kind of, or is it more like pay cash?
Pay cash, yep.
Yeah. So paying cash would cover any pricing scheme that the pharmacy decided to use directly for their patients. Cost plus is one type of paying cash where you basically are giving more information to the patient to explain why the price is what it is.
Yeah. Okay. So then I guess, so PBM, I have a pharmacy card in my wallet that my work gives me. We use Navitus. That's a PBM. What are some other PBMs? Do people know what we're talking about when we say PBM?
Good on your work for using a transparent PBM.
And I just searched them, and they seemed pretty good. Mm-hmm. And I was like, I don't know if this it just is fluff and copy on their website that makes them sound good, but I was like, they sound like Kyle might like this PBM, so, or whoever. Okay, so then CVS Caremark is Caremark the PBM?
Yeah, there's degrees of bad. I don't know that naming them actually will matter because they pretty much all, I mean, what's probably more relevant is like their operating model.
Sure. Yeah, I agree. So I was just trying to give examples, like what you have in your wallet is essentially the PBM, right? It's like your insurance provider for pharmacy coverage.
Yeah,
right?
we can name them verbally. So, the biggest one is, I think, Express Scripts still by market share. Second biggest is CVS Caremark. Third is OptumRx. Those three, I believe, cover what, 75 to 80% of the total market. So it's very monopolized across the big three. Then you have a bit of a drop off, and then you get into things like Humana, Prime Therapeutics. Then you have another drop off, and then there's a long tail. It's like, feel like every week I find out about some new tiny pharmacy or new tiny PBM that I never heard of before. So there's a lot of really small PBMs as well. It's just that they're kind of a rounding error when it comes to the total market share.
Of course, Mark Cuban.
Well, they're not really a PBM, I guess, in the traditional sense. I mean, they might be trying to come up with some kind of like contracted way of, of facilitating a cash price for a group of people to all pay the same cash price. I wouldn't call that a PBM, but I'd be interested to see what Kyle and Ben have to say on that subject.
Was that Mark Cuban? Is that what you said?
Yeah.
I was just kind of joking. I just threw Mark Cuban in there because we're naming
Oh, yeah.
PBMs. So I wasn't.
He
I think
did start
they're
a
doing.
PBM pharmacy, just to correct him. So they've got the Mark Cuban's first a manufacturer, then a PBM, then a pharmacy is the order that they rolled things out.
Their goal is to be a 100% vertical, which is interesting. But we can, that's further down, I guess, in the conversation. But the overall, and probably Benjamin and Luke can explain it a lot more. But I guess the most useful thing, aside from naming them, is also getting a sense of what they do. And so, from my understanding, and it's actually somewhat limited because I don't touch PBMs, so I don't spend a lot of time thinking about them. But they set formulary, so they're contracted with the different health plans to manage the pharmacy side of benefits. Hence their name, pharmacy benefit managers. So they're managing formulary, taking care of all prior authorizations, doing all rebates. You could say negotiation, but really it's like how much rebate are we getting? Ooh, and then some of the controversial things that goes around how much do they actually pass through to the end payer of that rebate. But they set formulary, manage rebates, contracts, the network. So they manage the network of pharmacies that are involved. Trying to think what other functions they really offer.
So yeah, manage formularies, manage rebates,
Yeah.
manage network of pharmacies. Formularies, rebates, pharmacies.
MAC pricing. MAC stands for maximum allowable costs. It's usually more relevant for generic drugs because generic drug pricing is one of the most convoluted and stupid things you'll ever experience in your life. Unless you are dealing with Kyle.
Or NADAC.
Well, even a lot of what we do is stupid, but we're trying our best. We at least are trying.
Yeah. Try. Like, I don't think it's stupid.
Our heart is in the right place.
All right, so these are some things that PBMs do: manage rebates, manage network of pharmacies, manage formulary, and then they figure out, I don't know what the word is, but do something at maximum allowable costs. You're seeing my screen, right, with all the post-it notes and weird stuff. Okay, cool.
Yeah.
All right, so keep going, I guess. So PBM, they work with employers, like basically the employer picks a PBM for their employees. Sometimes, okay.
Sometimes they'd work directly with employers. Sometimes they are a part of a package deal where the employer will elect to use an insurance carrier plus PBM combo. And so because all three of the, at least all of the top 5 PBMs are vertically integrated in some way with an insurance carrier. So what I mean by that is like United Health Group owns OptumRx. CVS Caremark owns, I always screw this up, Aetna, I think. And then Express Scripts and Cigna. No. Yeah, Express Scripts bought Cigna. So what my point is that like sometimes PBMs directly contract with whoever the health plan is. So a lot of, for people our age, almost everyone gets their insurance through their employer. So it's not wrong for you to write employer. A lot of employers do directly, select a PBM. But one of the possibilities is they could choose a PBM independent of the medical benefit. So a lot of times the medical benefit, like the system that you would use to pay your doctor to, see if you stitches or whatever, is separated out from the pharmacy benefit. So sometimes whoever's running the health plan may choose to do them together as a package deal, and sometimes they may choose to go out and source them separately.
Gotcha.
So in terms of what happens, when a patient walks in with a prescription, in the traditional world, you kind of just get their insurance card, process that, and you're like looking at which kind of submitting, BIN, PCN, all that good stuff to assign the specific PBM and also a contract. So it's pulling from the correct formulary, pulling from the correct MAC list, all that stuff. You're building that through, and then you're getting a response back. The other monopolies in this space that we haven't touched on is the switches, which Benjamin and Luke actually know the names of them. I don't have a switch, so I don't know what they are.
Relay Health.
Relay Health and Change Healthcare are the main two switches. Switches, for reference here, are like a switch in a computer network. They're just when you submit a claim from your pharmacy software to a PBM, you're actually sending it to a switch who then sends it to Caremark or Prime Therapeutics or whoever, based on the BIN and PCN that you submit. Because basically the PBMs and the pharmacy softwares don't want to maintain direct API connections to each other, or I guess XML connections to each other. And so they both contract with the intermediary there, so that basically there's 4 switches that I know about, instead of like 30 different software companies that you'd have to maintain a connection to. The 4 are, again, Change Healthcare is the biggest. They are in the process of getting bought by Optum, United Health. Relay Health, which is a division of McKesson, the big gigantic wholesaler. Then a smaller one is Powerline, who's owned by Red Sail Technologies, that owns 2 pharmacy systems. And then the other one that I know about is called RX Link. They're owned by the Pharmacist Providers of Oklahoma, which is a
My favorite people.
organization. So anyway, those are, there's just like, we've now discussed, I think, 5 parties to a prescription claim. The pharmacy, the patient, the end payer, the PBM, and the switch. So just get that in your head for a second.
Yeah, so pharmacy, PBM, obviously we're talking about. When you say payer, you mean the employer?
Well, it's the health plan. So like, a health plan can be representing all kinds of different entities. Like it could be a company that's paying for health insurance benefits for their employees. It could be a union. It could be a state government. It could be a Medicare plan. It could be a Medicaid plan. Basically, there's many, many different types of health plans.
Would that replace employer in this scenario?
Yeah, I would.
Okay.
I mean, I hate the term payer because at the end of the day, individuals are the only people that pay anything, and everybody else is just intermediaries. But you can leave it because that term is widely used.
Is PAYER in your opinion?
EROR doesn't matter.
It doesn't matter.
Okay.
So also, generally when I'm talking about this, I distinguish payer as being the person who actually cuts the check, like that might be United Healthcare, versus purchaser being like the employer or the health plan themselves, who might contract with United Healthcare to provide administrative services to their health plan. So I guess we're adding a 6th party now.
Hey, this is Eugene. I think one of the missing terms here is MCO, Managed Care Organization.
Yeah.
Sure.
And now we're making that lovely chart that says the US healthcare system, and it's got like patient in the bottom corner, and then it's got like this
Yeah.
massive array of pictures.
Am I recreating the wheel here? Does this already exist somewhere?
Probably not in any authoritative fashion.
Sure.
I just saw some
I
silly.
think you'll like the cost plus layout a little bit. It's a little less complex.
Yeah, we'll do all this. We'll be like, then we'll go to Blueberry's
Little easier to
website,
draw.
and we'll be like, what is okay? So managed care organization. I'm slow here. So what is that
I mean, that to me, that's just another,
term?
that's just another term for the health plan.
Okay.
Another aspect to think about in this, but I guess is only kind of tangentially related to all this is it a health plan that is fully insured or self-insured? So for example, let's say I worked for Target, right? I can almost assure you that Target is self-insured. So what that means is that like Target uses some kind of an entity to cover, they'll use a company like United Health Group or like CVS or whatever to cover the stuff. But at the end of the day, once all the financial terms are determined, like Target is just directly paying for everything. So that's self-insured. They don't I don't even call it really insurance. It's just that Target just has this big pot of money that they use to pay all the medical and pharmacy charges for their employees. On the other hand, if you worked for a really small company, they're more likely to be fully insured, in which case they pay a premium for every person over to an insurance company like United Health Group or Aetna, Cigna, whatever. But at that point, they are absolved of the financial risk. Like the proverbial check in the fully insured model is actually being written by the insurance company. So one giant misunderstanding that a lot of people have in America is when they get something covered through their insurance, and that insurance is something that they get through their employer, they might have the attitude of like, I don't care if I just stick it to the insurance company because, screw them. But if they're working in an environment where their employer is self-insured, they're not screwing the insurance company at all. They're screwing their employer. So that you just have to understand like how all the money flows actually work, and at the end of the day, who's actually on the hook for the financial risk.
So let's take a step back from insurance. I know insurance is super important to this, but like I want to get to the point where we're talking about like a specific person walking up to let's talk to an example. Like I'm a person walking up to a pharmacy with a prescription. Pick a specific pharmacy, like let's pick CVS because we know they're vertically integrated with some of this stuff, right? Just to have one example to go through maybe. And what happens there? And I'm using my insurance. So we started tracking that out, right? You hand your insurance card to the pharmacist. He's got a PCN, a BIN number, an ID, whatever. You adjudicate that claim with the card information to now a switch is the first place that goes. Is that right? Generally?
It's all pretty much instantaneous, but yeah. So
okay, we're getting into that level of detail though. So
right. So
yeah.
I submit a claim. It goes from my server to the switch, which in my case would be Powerline. In most cases, it's probably Change Healthcare or Relay Health. And then they forward that claim to the according to the BIN and PCN. So probably 0043336 ADV is on your card. They route it to Caremark. Caremark then in their system calls several different databases. So they will call their eligibility database to say, are you eligible for payment of a claim? So are you up to date on your premiums? Are you still a member of the health plan? They call their formulary database to see if the drug product that is on stock, that is being billed for, is on the formulary. And if so, which tier it is. So like, say it's lisinopril 20 milligrams. They say, okay, this is a tier 1 generic. It's covered you're eligible for payment of the claim. They then call their pricing, well, probably they first call their network database to say, okay, this pharmacy is under this contract. So this is, but we're saying CVS. So the CVS contract has this price list. And then they call the price database and they say, okay, this medication has a maximum allowable cost of 3 cents a tablet. So we're giving you 90 tablets, so we'll do 3 cents a tablet times 90 tablets, plus the contract with the pharmacy says they get a 50-cent dispense fee. They'll then they then compare that to the submitted information on the claim, because the pricing model will pay at the lowest of 4 numbers. The submitted charge for the prescription. So the pharmacy says, this particular prescription, I want $100 for it. The pharmacy's usual and customary or cash price, as it were, if you were paying out of pocket. And we said cash pay. I prefer the term pay out of pocket because people think if you say cash that you literally have to be paying in dollar bills, but it's just not involving your insurance. So pay out of pocket. Anyway, they compare, so the charge, the usual and customary price, the pharmacy will have a contractual discount off of a benchmark price called average wholesale price. So my contract with Caremark says AWP minus 30%. So they would say this NDC, the average wholesale price listed in the FDB database is for this quantity of tablets is $123. We'll knock a 30% discount off of that, and that gives us like $90 or something. And then the fourth price is their internal maximum allowable cost, which is just a price they set internally, theoretically based on a market survey of what prices are actually available in the market. But talk to any independent pharmacy owner and they'll tell you how well that works out. And Luke can tell you about how often people are happy about that process. Because that's essentially what he does, is managing a list of maximum allowables for Medicaid.
That is true.
And so anyway, so they compare those 4 prices and they come back with, okay, this is the price that's going to be paid on this prescription. The lowest of those 4 prices was the MAC price of 3 cents a tablet plus 50 cents. So we'll return that price as the total amount paid for the prescription. And then they call another database, which is the terms of your insurance contract. So say you have a deductible of $1,000. They'll say, okay, apply $4 or whatever it is to your deductible. Or say you have a $0 deductible and you have a $10 copayment for tier 1 generics. They'll say, okay, this is still $4 or whatever it is. So we're just going to return a price of $4 and that'll all be the patient's responsibility. If it was a different medication that had a higher price, the allowable cost was $50, but your copay said $10 and you've met your deductible, they'll return a copay of $10 and a price to be paid from the PBM to the pharmacy of $40. So they'll return that total price $50, and then the price for the copayment will be $10, and the price to be paid from the plan to the pharmacy will be $40. That all then gets sent back to the pharmacy in an XML transaction called in the D.0 transmission standard. And it gets sent back to the pharmacy by way of the switch. So the switch sees every single transaction coming in and out. And so that information anyway will go to the switch. And then that'll go to the pharmacy. The pharmacy will then get back a prescription claim response. they'll then print a label that says $10 for this NDC, or $4 or whatever price it is that is to be charged to the patient. And then they'll have accounts receivable from that PBM now of $40 in the $50 drug case and $0 in the $10 drug case. Does that make sense?
There's a lot of info, but
Like, how many databases did we just call?
You know, when you look at it through that lens, it is kind of amazing that it all happens in like 3 to 4 seconds, you know?
Like 1 second in a lot of cases. It's
Yeah.
nuts.
Yeah. I mean, I remember getting
I just know
impatient
it-
when it would take more than 5 seconds back in my dispensing days, you know, it'd be like, come on, computer, what the hell, you know, and there's a lot going on.
Yeah.
I think Joey wins the award for best note taking I've ever seen.
Yes.
I was trying to keep up.
I'm impressed as I look at this, how well you take down.
Do we want to make some corrections? So I was going as fast as I could, but you said it charge, you were calling this charge. Is that another name for the usual customary?
So
Or-
it's two different numbers. And that's one of the things that a lot of folks don't realize is that you can submit a different charge than your cash price. So you might set your computer to say, my cash price is $100, but I already know that my contract with this PBM is at AWP minus 30%. So I will submit a charge to them of AWP minus 30%. So it's two different numbers. In almost every single prescription claim case, they're going to be the same number because pharmacies don't usually modify those. A couple of exceptions that I particularly would do is like my state Department of Health provided Narcan to us at no charge on the stipulation that we dispense it at no charge. So if I pull Narcan from my regular inventory, I'm going to submit a charge of like $200 at a usual and customary price of $200 or whatever it is. I don't even know what Narcan is anymore.
It just went generic.
It did, but it's actually more expensive for the generic than the brand right now,
Okay.
which is a whole fascinating piece of information. But at least that was the price that my wholesaler, who I'm sure you have all sorts of love for, Luke, set a price that was like, I think the brand under my contract is like $197 and the generic is like $198. Because why not? What a stupid problem.
We'll probably run out of time, but just keep in mind that whatever stupid ass diagrams we're going to put together for PBMs, there's an equal amount of stupid ass diagrams for wholesalers.
Yeah, and I guess on that note, when I talk about drug pricing, I divide the world into two pieces. There's the buy side, which is pharmacy acquiring drug, and the sell side, which is pharmacy giving the drug out. And
Yeah.
a lot of mistakes that politicians and lay people make about understanding what a PBM is thinking that PBM is a wholesaler on the buy side, not on the sell side. And that gets you just into all sorts of confusion if you make that category error of thinking that these are the same system, but basically it's two different sides of the same transaction. Well, transaction of purchasing and transaction of selling.
They're not, I mean, they are connected in some ways, but yeah. They are different and you have to understand the logic that gets applied to both.
So these low support numbers, is this like the charge equals, and we're describing what that charge could be?
It would be determining, like, it would be determining how the pharmacy is going to get reimbursed.
Okay.
This would
Pharmacy,
be reimbursement equals the lowest of these. And it's the charge, the usual and customary, the contract discount rate, or a MAC price.
charge, usual and customary. Okay, so out of pocket, obviously we were just talking about that during that, so it doesn't count here.
And just to be a
And
grammar.
A lot of people don't.
Go ahead. Go ahead, Kyle.
And a lot of people, oh yeah, a lot of people don't realize, like, you're kind of new to the pharmacy space, you wouldn't realize that like the cash price, out of pocket price, and correct me if I'm wrong, Benjamin, but that's always going to be your highest out of all of those. And then Mac is probably always going to be the lowest out of all those. So you might ask why, so that's why that's why I opened Blueberry Pharmacy, is because why, why, you might ask, why is the cash price or the out-of-pocket price the highest, and so it actually, from my understanding, comes back to Medicare. The government has to be the lowest payer, and so you can't submit a cash price or in of $50, or you can't charge somebody a cash price of $50 and then tell Medicare that your usual and customary or any of those other ones is $100, because you're actually giving that cash paying customer a lower price.
Yeah.
And so I believe that's the case, but
Yeah, it's bad incentives. Basically, pharmacies have every incentive to raise their usual and customary as high as they can, because in theory, there might be someone that will pay them at that number, but most of the time they are not. And so it's just a very dysfunctional. Two quick things I'll add, just because I'm a grammar bitch sometimes. Usually, when I've seen it in actual contracts and the way they talk about it in Medicaid, it's lesser of, not lowest of. So
Yeah.
I don't know if you want to know that, but and then it's probably worth pointing out that of those four things there, the top two, the charge and the usual and customary, are determined by the pharmacy. The bottom two are determined by the PBM. So it's kind of important to understand like who sets those.
Right, because most independent pharmacists will argue that the PBM always sets the price. So that's because they always they submit a charge and a usual and customary that is well above the maximum allowable or the contractual discount price. And when a PBM sends back that transaction to the pharmacy, they'll identify how they're determining what the pharmacy's reimbursement is. They'll say, code 01, this is, I'm paying you what you asked for, your charge. 02 is I'm paying your cash price. 03 is I'm paying you your AWP discount, and 6 and 7 are MAC price. There's also 20 other codes, and I'm not entirely certain what they do, but they come back on claims.
Is charge just a made up number? What is charge? Like I keep asking that. I'm sorry, but I just don't get what charge is. Maybe just a simple example.
So you and I are just talking, and I say, you know what, I'll charge you $10 to give you this prescription. That's the charge, right? It's whatever price I want to set as the pharmacy.
Okay.
same as the out-of-pocket price.
It's usually the same as the out-of-pocket price, and it's usually just determined by the pharmacy's computer system based on an algorithm of like the pharmacy will call their AWP database and say, just submit AWP plus $12.
Which for a generic drug is going to be a very inflated price.
Right. Ondansetron is my favorite example of this. Its AWP is $40 a tablet. So for 30 tablets, you're submitting a price of like $1,200. Ondansetron tablets have a typical acquisition price of about $4 per 30 tablets. And so if the pharmacy is just using that algorithmic AWP plus $12, they'll submit a price of $1,212. And so no PBM in their right mind is ever going to pay that price. No person in their right mind is ever going to pay that price, but the pharmacy's just submitting a price because they have to submit something, and so they just rely on the algorithm to send it for them. And most pharmacies just will submit some kind of price like that. For other drugs, the AWP has some meaning. Like diazepam has an AWP per tablet of like 4 cents, and that's pretty close to what it actually costs.
Is that, yeah, the only caveat I would add to that is that might just be on the NDC that you're purchasing. Like there could be an NDC for diazepam 2 milligram tablets where the AWP is a realistic price, and there could be another one where it's 10 or 100x that.
Yeah, and that's the case with metformin for sure. Heritage brand metformin has an AWP of like $20 per typical dispensing and a cost of like $10 per typical dispensing.
I feel like at this point, we should probably stop and talk about what AWP and WAC are.
Yeah, that would be good. And usual and customary too. I don't know what that is really either. So yeah.
Oh,
How do we, let's see. So I'm gonna
Ben, you can talk about usual and customary. I don't mind talking about AWP and WAC.
And before we lose sight of the forest or whatever, I don't know. But I think we're going on the right path. This is what I want to talk about, I think, right? Like, I mean, you guys don't know what I think I want to talk about, but you know what I mean? Like, we haven't gotten discount cards yet or anything. But I think
Well,
this is super interesting.
The good news is that a lot of the logic for a commercial PBM claim actually is exactly the same as it is for a discount card. It's just that with a discount card, you pay the full liability of whatever the final output of all this is, versus if it's through your employer or whatever, your employer will probably pay part of it and you'll pay part of it. That's the only real difference.
Okay, let's keep down the road then. Let's define some of these things. So we've
Okay,
got
so-
AWP, which I don't really have anywhere except here.
Yeah. So
It's not really in the flow chart. It's just probably like a reference table somewhere.
Yeah, it gets called at, like, when that PBM pulls their price list, that they call their price list database, they're typically calling at minimum the AWP. AWP is jokingly referred to as ain't what's paid, which is a true statement because I've never seen a claim paid at AWP, but it's also extremely false because basically every single time you see funny business with pricing, AWP is involved. Like I saw on LinkedIn this one time, this doctor was berating a hospital for going to a family whose kid had leukemia and was being prescribed Gleevec. And the hospital said, we'd like $11,592 for this to start your child on Gleevec. And then there was some savvy person in the room who went and pulled up CodeRx and saw that you could get generic Gleevec at the Kroger down the street for like $100 or something. And the hospital just said, the hospital administrator who was in the room just said, yeah, we'll match that. That $11,592 price had to come from somewhere, and it happens to be on the nose. It's the average wholesale price of the medication. And the average wholesale price is a price that is set by the manufacturer of that product. And so when if you were Aurobindo Pharmaceuticals or Pfizer, you set a price for your medication. Yes, you can have my chocolate. That's my daughter. But the manufacturer says, okay, I made NDC number 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11.
That'd be 13 digits.
Sure, whatever. That's my GTIN, fine. I'm going to set a AWP for this of $12 a tablet. And then what they actually sell it for in the generic marketplace can be completely untethered from that price. And that's exactly the case in the case of imatinib or ondansetron, is it's completely untethered. And if you follow 46 Brooklyn, they're drug price research people out of Ohio. They have documented that the spread between the actual acquisition cost, the NADAC that Luke manages, and the AWP increases with the number of manufacturers in a market. So with one or two manufacturers, the AWP is a good approximation of the actual price. It's inflated because it's supposed to be like the MSRP of the medication, as it were. Like the list price for this is whatever. But as you get to like
So
11,
real quick, one to two manufacturers is a great example of the brand name drug.
Yeah.
It's close
And
to, yeah.
with brand name drugs, there's actually a legal definition of what the AWP is for the medication. It was in 2008, I believe, there was a lawsuit where a bunch of unions sued McKesson, First Data Bank, and the other drug price publisher,
Metaspan.
Metaspan. They sued them for inflating the AWP because the wholesale acquisition cost, the price at which Pfizer sells a drug to Cardinal for, or sells a drug to McKesson for, that's the price that actually they invoice. And so if they sell a bottle of Eliquis, it'll be like $496. And McKesson and First Data Bank had conspired to make the published AWP be that price plus a 25% markup. And the unions thought that they were overpaying, which they were. And so now after that lawsuit, the price that First Data Bank publishes as the AWP for every brand drug is the WAC plus a 20% markup. So if before a medication had a wholesale acquisition cost, the price that Pfizer gets paid when they sell it of $100, it would have a price of an AWP of $125, and now it's $120. But that's historical context. The 25% doesn't really matter. What really matters is today, the AWP for branded products is WAC plus a 20% markup.
Yep.
And the usual and customary, that Luke was asking me to touch on that. So the usual and customary is theoretically the price that the pharmacy would charge to someone who's paying out of pocket. This is mostly a fiction because mostly pharmacies just play with discount cards to deal with people that are actually paying out of pocket. But the usual and customary price would be the price that you would charge to someone who just walked into your pharmacy off the street and said, "I don't have insurance, give me 90 lisinopril." And you'd say, "Okay, that's going to be $35 or whatever." And that you are, as a pharmacy, you're contractually obligated to the various PBMs to submit that price on the claim. And pharmacies get in trouble for playing games with this every now and again. And sometimes they get in trouble and sometimes they win their cases. Walgreens got in big trouble for playing with a like loyalty program in-house where they said that their usual and customary price was X, but actually they would just have their pharmacies process it under this other bin. And this is a very common tactic in the industry.
Get it right. It was called the Prescription Savings Club, and I signed up hundreds of people to do it.
Which is like good for you being a good employee. But anyway, they got in big trouble with a lawsuit with various unions and various insurance companies who said that the price on the Prescription Savings Club should have been the price that they were submitting as the usual and customary, but instead they were submitting some price that was 10x that. And so there are, not always, but a decent proportion of the time, that means that the insurance company was therefore overpaying according to contract. Because if the usual and customary, in reality, the price that someone would pay out of pocket is $10 for medication, the Walmart $4 list, it's $4. If they submit a price to an insurance company of $100 and the PBM says, okay, our contract says we're going to pay you 30, then the person paying for that is now overpaying by $26.
So can I state that back? I'm trying
Yeah.
to follow along. That's why I'm
Please.
looking like I'm sleeping, but I'm not. So did they get in trouble for saying that the usual and customary, like having it in their system that usual customary is really high so they could bill, but then whenever anybody picked up a prescription and said, I want to pay cash, they said, oh, I want to put it through this discount card, and they gave them like a fake, like more like the actual cash price, but it was just because they had a discount card to make it the actual cash price. Is that accurate? That's
Exactly.
that's the grift there or whatever. Okay.
Yep.
So that the UNC tends to be higher so that they could bill higher to most insurance companies, but it's not an accurate reflection of the cash price.
Yep.
Okay.
Oftentimes, and this is actually why GoodRx and discount cards exist, is because if it's a third party that's setting that cash price, then it's no longer a problem. Because if I say that the cash price is $12 and I charge you $12, but then I submit a price to your insurance of 100, then I am defrauding your insurance company. If on the other hand, I say it's $100 to your insurance company and $100 to GoodRx, and GoodRx tells me to charge you $12, then no one's defrauding the insurance company anymore. And so GoodRx benefits the pharmacy and they charge the pharmacy a fee to be able to give people discounts like this. Because at the end of the day, pharmacies make money by selling drugs. And they want to sell more of them. And if someone's not going to pay $100 for a product, they would be happy to sell it to them for $12 and pay GoodRx $3 for the service of making sure that the person actually got the medication. That's the theory, at least. Most pharmacy owners most independent pharmacy owners just don't care about this whole defrauding the insurance company thing. And so they don't care about the benefit that GoodRx, the protection that GoodRx brings to chain pharmacies. And just see it as a big fraud, which it is, because it's facilitating the fraudulently high pricing. But anyway.
Yeah, another way to say that is that GoodRx essentially allows pharmacies to maintain their ridiculously high usual and customary prices for submitting to insurance claims, while also creating a secondary pathway to charge a more reasonable price to cash paying patients. It's basically it allows the farce to continue.
Yes, this is my biggest frustration with and this is what I really want pharmacists that use these coupon cards to understand, is that and really society at large is it's billed, and if you look at all the GoodRx's marketing materials and whatnot, and any discount cards marketing materials, it's all about, we save you this amount of money, but it's almost, and I forget I don't know if it's a straw man or what kind of argument that is, but essentially it's incorrect, because they're operating under the assumption that that's the only option. And so if you look at the other option, which would be, patient may actually go to an independent where there's ability to change price. So in the world of discount cards, they're saying, if we don't exist, the only option is for the patient to pay usual and customary, and therefore we save them. In the case of imatinib or Gleevec, CVS's usual and customary is $19,000, and the GoodRx coupon is like $787. So GoodRx is saying we saved this patient $19,000+ dollars, but in reality, that patient was either never going to take it or go and actually find a more reasonable price. So what actually would have probably happened had GoodRx and other coupon cards not come to existence and still be in play, is we'd actually have a faster transition to a fair and transparent marketplace than we do currently, because there would have been a lot more competition, a lot more price transparency early on. But because the coupon cards exist, it's almost to some extent like GoodRx, they would too quickly monopolize, like eat away their core business, like that's their core business. So they're almost now in a self-perpetuating, they don't want to change the actual system. They don't want prices to actually normalize or become fair, because that too quickly cannibalizes their current business. So all these perverse incentives at play solely because of the pricing game. And so now there's so many actors in the system that want that same process to exist. And then it's almost like a self-perpetuating cycle.
Yeah, the whole system is corrupt, and basically, that's why what Kyle does is so amazing, is that basically, it kind of shows exactly how the whole system is just corrupted. And, it's sad because, like, a lot of people, even if they mean well, if they still are trying to participate within the current system, you don't win. The system corrupts you. You don't fix the system. So you kind of have to leave the system entirely in order to do something that's fair.
Can we just really quickly draw out Kyle's business model? Or is it not easy? I mean, literally, it's like, what is the number that you use, Kyle, for the pricing of the drugs, of the numbers we just talked about?
We'll simplify it and not pretend there's no membership level. So it's just cost plus 10. So you walk in with a prescription, I look at my acquisition costs, they add on $10, and they leave.
And which number is the cost coming from? Is this just literally what you bought it for?
Yeah, so there's a couple factors as so first is what we bought it for, then we add in the price of all the fixed costs, so like cost of label, cost of the vial, cost of the
no, yeah, I get that. Yeah, I meant like, is the cost to purchase? Is it one of the numbers we were talking about?
Yeah, we don't do. Yeah, exactly. Yes, that's our cost. It's not like AWP or WAC or NADAC or anything like that.
So like today, if you bought a bottle of whatever for $10, and tomorrow or next week it went up to $12, you would charge $10 today, and like next week it'd be $12. Like goes up and down with whatever you bought it for. Or is it some sort of average? Oh yeah, so basically as simple as that. Okay.
Which is actually awesome, because I actually did this. We just hired a pharmacist and did this exercise with him, because he asked, how do we respond to patients that say, oh, I don't know, it could fluctuate too much or whatnot. So we pulled up 3 different patients' profiles, and we've only been open 2 years, but because generic drugs are deflationary, over those 2 years, all 3 or 4 patients, I forget how many we looked up, all of them are actually paying less now than they were when they first started. And it's because of, buying better, but also, just the cost of drugs going down. And so it's almost like the model actually helps every time we save by buying better or drug costs going down, patient actually saves money as well. And that's actually the interesting thing, which I shared with him, is, that decrease in patient cost actually coincided with, we actually increased our cost plus in that time as well, because we weren't properly accounting for the e-script fees at the time. So we actually added on a 18 cents increase to each script about a year ago to account for e-script fees. And so patients are still paying lower now than they were when we first started, just because of buying better.
One of this is not an ad for Blueberry Pharmacy, though we all love Blueberry Pharmacy here, but just to see like that is compared, we've been talking for an hour. We're not even close to getting into the details of some of this stuff.
And I also want to highlight, I'm not the only one that does cost plus. Benjamin actually does cost plus. So just highlighting that he's working within the current system.
Yeah.
And
I guess it should be the cost plus pharmacy model. Yeah.
Yeah, there's probably at least a half dozen pharmacies that do that. And to fit Kyle into our bigger picture of the rest of the market, that cost plus $10 would be the charge and the usual and customary price, right? That is his charge. And so what makes Kyle unique in the market is not that he's able to source medications better than anybody else and get prices lower there. It's that his charges are based on the cost and not based on made up numbers. And like, frankly, his patients could go and get reimbursement and credit for their medication, so long as they're not Medicare, they could submit the receipt that he gives them that says $12 on it to their insurance. Their insurance would then adjudicate it through that same process and say, okay, in almost every case, they would say, okay, the lowest of those four numbers is the charge here. And so they would then say, okay, this medication that you got is a tier 1 generic, and you qualify for $10 copay, we'll cut you a check for $2. In most cases, that's not going to be worth the person's time, but they could. That process does exist. It's called direct member reimbursement. And it's how actually pharmacy claims were before PBMs really took hold. And before, there was a transition period from everyone was basically doing what Kyle's doing. They would just set a price for any given product and charge it out of pocket to everybody. And then unions and employers started to add prescription coverage. And so they would just have people submit their receipts to their insurance. And then PBMs were invented. The first one was called, I believe the first one was PCS, Prescription Card Services, which is now part of Caremark. And they would just print these little cards that said, mail a claim to this address, collect this copay from the person, and we'll cut you a check for whatever amount over that is needed. And then from there, they grew into these monstrosities that control most of the market. But like what Kyle's doing is like basically what my grandpa did when he started the pharmacy in 1954. There were no PBMs until like the 70s and 80s. And so it's beautiful because it's how markets normally work in the absence of added unneeded complexity.
And it's logical,
Which,
right? I mean, yeah.
Just to provide a parallel, in one of the I guess prescribers that we work closest with in Pittsburgh, he's actually a direct pay physician as well. So not direct primary care. He's actually the only one in the nation that I know that does this. It's just $35 per visit and then $10 for each additional problem. And I was explaining how he operates to my mother-in-law, and she's like, oh, that's how, like, he's the only person in the office. There's no front end person or nurse, PA, anything like that. There's no scheduling or anything like that. And so I was explaining it to my mother-in-law. She's like, oh, that's exactly how doctors used to be. You used to be able to always get same day appointments, or not even appointments. You kind of just like walk in, wait to be seen. She's like, this would have been in the 60s or something like that. She's like, it was $5 for the visit. You walk out. So I did an inflationary adjustment on $5, found out that it's pretty much to the nose $35. So basically, to the comment of our model being very similar to how it used to be, I think we're kind of seeing this within healthcare, whether it's direct primary care or other things, where there's these middle players really don't need to exist in this marketplace. They're actually adding to the cost of healthcare. And so I think as more, it'll start with first the employers that are self-funded, but as more people realize that all of this adds to the cost, we'll see a lot more of this happening.
The physicians have a similar model that is kind of similar, where it's just kind of a flat fee. Is what you're saying. Or the direct pay is what we called it.
Yeah, direct pay. Yeah.
Some physicians, I mean, most physicians probably play a similar game to what most pharmacies do. If they submit a charge to a insurance carrier for $400. I mean, if you look at your explanation of benefits that you get from your insurance company every time you go and see the doctor, it says submitted charge like $400, plan allowable amount, which would be the maximum allowable cost, right? $200. Plan pay $160, copay $40. It's the same concept. And community pharmacy is primary care, and the same idiocy, like, it makes sense to have insurance coverage for hospital stays. it's an insurable event. Like this is something that Kyle was talking about at the very beginning here, was the concept of insurable risk. An insurable risk is something that has a pretty known population level event frequency. So like, you know that about 1 in 10,000 people will have a car accident or whatever in any given year. But you can't know who in the population is going to have that event. And it would otherwise be catastrophic to the person if they, it's a catastrophic event where it costs so much money that if you were to try to pay it out of pocket, you would go bankrupt. And it's rare enough that it makes sense to pre-purchase. And so when you have those 4 elements, you can, that's where it makes sense to purchase insurance. Like for an emergency car accident going to the hospital, that's a situation that makes sense here because you don't know that you're going to get into a car accident. You know that some people do all the time. And so you can calculate about how much money it costs population wide. But any given person getting into a car accident would be a horrible financial event. And so so an insurance company can sell a policy where they will pay for that cost, provided you pay them a premium. Generic drugs and primary care physicians are not insurable events, and yet we use insurance to pay for them, which is a stupid way to pay for things. Like generic drugs don't fit the rare event because basically like lisinopril, you take it every month until you die, or until you switch medications, but you know that you're going to be on it. So it's not a unknown event. It's super common. It's ridiculously cheap. You don't need to have insurance to pay for it. And so involving all of these 3rd, 4th, 5th, 6th parties in the process, to Kyle's point, substantially increases the cost of obtaining that medication. So
let me ask one more question about his definitions, and then let's talk about what happens, like the PBM. I've heard of the clawbacks, and I've heard, like, what do they do? What's a rebate? And we're running out of time. And I know you guys, if you got to leave, feel free, let me know. We can talk about some other time. Because I can stay on to like 3:15 maybe, but I know people are busy. So, okay. So I had a question about AWP. So manufacturers make this number up for their product. This goes to FDB has this information, Metaspan has this information. Is it like publicly known, or is it just like reported to FDB and Metaspan and like they just aggregate it? Like, how does that number get into these databases? And that seems like a loaded question. That is like, you're laughing, Luke, but like, I'm like, why do you have to pay for FTB or whatever to like get to know how much a drug costs? Like,
okay, well, I can take this one. So like Benjamin said, there was a massive lawsuit over AWP in the aughts. And so much so that First Data Bank actually stopped publishing AWP entirely. Now that they replaced it with what they call a suggested wholesale price, which of course everyone knows is what they mean AWP, but because they're, wussies or whatever, they just decided, oh, well, we're not even publishing AWP anymore, even though they are. So what I've learned now in my job is that my new job is I kind of get like a front row seat to all this stuff. And we're actually going through kind of a small version of hell right now related to the exact question that you just posed, is how does the public find out what the WAC or the AWP for a drug is? Okay. So the most important thing to understand is that if a drug is branded, if it's if still monopoly or whatever, under patent, the AWP doesn't really matter. What matters now is the WAC. the wholesale acquisition cost. Now, what's perverse is that a lot of the contracts that PBMs sign with pharmacies are still denoted in AWP. They're not denoted in WAC, but it doesn't really matter because 99.9% of the time, the AWP is just the WAC times 1.2. So I'm just telling you this, that the AWP, like to manufacturers, like they don't really care what the AWP is. They care what the WAC is. And yes, they set it. Manufacturers set the WAC. All these terms, it's very Orwellian because like WAC stands for wholesale acquisition cost. So any reasonable person would say, oh, this must be the price the manufacturers charge a wholesaler to acquire the drug, wholesale acquisition cost. We know that that's not actually the case. Most of it, so when we collect all of our surveys, because what we do is we actually have the real information that pharmacies are purchasing branded drugs at. Pharmacies typically are able to purchase branded drugs at WAC minus 4%. That's the average. Now, that doesn't make any sense if you think about it for a second, because obviously the pharmacies are going to have to pay a higher price than the wholesaler does, because otherwise the wholesaler would lose money on the transaction, right? So that the chain of title goes: manufacturer sells to wholesaler, wholesaler sells to pharmacy. So if on branded drugs, if pharmacies are buying something at WAC minus 4%, then clearly the wholesalers are buying it at something that's lesser than that. And then when they sell it to the pharmacies at WAC minus 4%, the wholesaler is making some kind of a profit.
This
Now,
is for branded drugs, or are we talking about only branded drugs?
Branded drugs only. This only applies to branded drugs.
Can I
Sure.
clarify this? So wholesalers do purchase product from manufacturers at WAC. That is what is on the invoice. They then get a rebate from the manufacturer for some amount, typically 2.5%. Sometimes more. It depends on the leverage that the parties have. They get a rebate for not buying up all of the product right before the end of the year when the manufacturer increases the price. So long as the wholesaler doesn't do that, then the manufacturer gives them a rebate that's like 5%, 6%. But honestly, it's perfectly legitimate for me to believe that it's somewhere around 2.5% is their rebate. Because wholesalers that sell prime vendor agreements with a pharmacy, there's like, you sign an agreement that says you'll buy 90% of your drugs from Cardinal. Cardinal can sell you their brand products at WAC minus 7, WAC minus 8, whatever, but they make that contingent on you purchasing at least X dollars of generics from them. And they mark up those generics like crazy.
I'm getting to that.
Yeah, so the pharmacies are able to buy it at WAC minus 4, but which implies that the manufacturers are selling it somewhere less than minus 4, but not necessarily. And I know for a fact though that the actual invoice price that the wholesaler pays to the manufacturer is at WAC. That's not the final price because they play these games of rebates, but that is what is on the invoice. That is what they pay for it when they take title.
Okay, that's fine. I mean, that doesn't really change anything in terms of, my perception of it. But yeah, so
Right.
there's some kind of, funny money, funny accounting going on in the background or whatever. Or, maybe they actually do sell brands at a minor loss just as a loss leader to get the pharmacies to buy, 90% of their generic drugs from them too. I don't know. All I know is I look at hundreds of invoices every day, and in general, pharmacies buy branded drugs at about WAC minus 4%. So that's for brands. For generic drugs, and I cannot emphasize this enough, both the AWP and the WAC are completely meaningless numbers. it is gibberish. It doesn't mean anything. So if you're trying to pay a pharmacy and AWP and WAC are involved in the formula that you're using to determine what the pharmacy is going to get paid for that, it's gibberish. Like, garbage in, garbage out or whatever. If for generic drugs, if AWP, if you're using WAC or AWP for anything related to generic drugs, it's garbage. I cannot stress this enough. Like they're meaningless numbers. A lot of drugs are, when we look at the acquisition costs that pharmacies pay to acquire the product, it's a 98, 99% discount from either the WAC or the AWP. I mean, think about that, right? Like the metaphor I like to throw out is like,
Say that one more time before you go. Is it the price that pharmacies actually acquire drugs for is 99%
right? So like
less than the
when Benjamin or Kyle go to actually buy generic drugs from their wholesaler, like there is zero correlation to what the WAC or the AWP is for that NDC. It might be, in some cases, they might buy it for WAC minus 10%. In some cases, it might be WAC minus 99%. It could be anything in between. It's gibberish.
In a couple cases that we've talked about, it might be WAC plus 30%.
Right. That's true. Yes.
It's even screwier.
It's, yeah, we won't even get into that because that's just, I still don't understand that. But what I can tell you with 100% confidence is that for generic drugs, the AWP and the WAC are completely meaningless numbers.
I think I got that nailed down here with all this stuff.
Yeah. So if you learn anything today, learn that.
So Luke, what three-letter abbreviation actually describes generic prices? Or is there one?
Well, there basically isn't one. What
about MAC prices?
Well,
Closest would be what Luke does.
right.
5-letter acronym.
So we, because of this problem, right? I think anybody that thought about this for 10 seconds would realize that, like, if there's no reference point for understanding what a reasonable price is to pay for a generic drug, and by the way, I mean, like, we have to call a spade a spade. Like, it's basically wide scale collusion implicitly amongst wholesalers, pharmacies, and PBMs they're all kind of in on it together to not tell the public what the real prices for generic drugs are. I mean, that has to be true. Like at a wide scale, like there's no like actual reference point for what a reasonable price for a generic drug is. The only way we get to that place is that implicitly wholesalers, pharmacies, and PBMs all kind of collude with each other to make that the case. So the government realized this. Go ahead.
I was going to say, and Luke, you saying this reminds me of your big ask of Blueberry Pharmacy, which we will eventually do, which is to completely publish all of our invoices completely transparently in a downloadable CSV at some point.
Right. Thank you, Kyle. So what? Okay. So obviously this is a massive problem, right? With like you and we even see every day I look at drugs and we look at all these invoices, and it could be a generic drug and one pharmacy is paying the wholesaler 10x the price that another pharmacy is paying for the same thing. That happens all the time. So basically that just means that the pharmacies have no understanding of what the other pharmacies are paying for this. There's no way to competitively know what a good price is for something, because otherwise that would never happen. So what I do is basically, this is a massive problem on a societal scale. So the government basically realized that the market failed, and they said, okay, we have to create this thing where we're more or less going to, and it's weird because they don't force pharmacies to participate. It's voluntary. But they started the process of this around 2010, and it actually came into fruition around 2013. They created this NADAC concept. So NADAC stands for National Average Drug Acquisition Cost. And what we do is we send out surveys, and pharmacies, and some pharmacies, enough to make it work somewhat reasonably, are willing to actually tell us what their true acquisition costs are. The carrot that makes this system work is that we want to reimburse the pharmacies through a true, what's called a professional dispensing fee. So what I call the big lie in pharmacy is that if you look at dispensing fees that are like 50 cents, $1, whatever, right? Like it's been drilled into our heads a million times that when we do cost of dispensing surveys, it costs somewhere between $10 and $15 per prescription to dispense a prescription when you take into account everyone's salaries and the electricity bill and all that stuff, right? So if we have a dispensing fee that's 50 cents and we know that a prescription costs $12 to even dispense, then if we took the prices at face value, then a pharmacy would just basically lose $11.50 on every prescription, and subsequently every pharmacy in America would close within 1 month. Obviously that hasn't happened. So the giant lie is that the pharmacies are making all of their margin under the current corrupt system, is that the pharmacies are currently making a markup on the product, and then they don't really get any money. Like the dispensing fees are a pittance.
Can you say some of that again? So the 50 cents, $12 example, you're saying it, and
Can I talk to this point for a sec?
Yeah, go ahead.
So basically, if you look at a pharmacy's profit and loss statement, you have sales, you have cost of goods, and then you have everything between cost of goods and profit. So salaries, rent, electricity, all of that. If you take that number, all of those expenses that aren't buying the drug itself, if you take all of those expenses and divide them by the number of prescriptions that a pharmacy does in a year, that's what we refer to as the cost of dispensing. And as Luke pointed out, depending on the survey, it ranges somewhere from $8 to as high as $22 is the highest that I've seen. In most cases, we say it's somewhere between $10 and $15. That is what a pharmacy needs to be able to pay its staff and have a small profit. So if the pharmacy gets paid less than that, then they are slowly going out of business. And if they get paid more than that, then they're making a profit.
Yeah.
And
so that's just literally like every script a pharmacy fills, they should be collecting $10 to $15 just for filling that script, just to keep the lights on and pay their employees.
Right, and you could make that go down if you paid pharmacists $20 an hour. You could make it go down. That's a big chunk of it's the pharmacist salary. If you staff less, you can make that number go down. That's why we have less staffing. In my view, is that the big chain pharmacies want to drive the cost of dispensing down. And so anyway, that's what the cost of dispensing is. And so Medicaid is like congressionally mandated to pay based on the actual cost of the drug, which we use as a proxy, the NADAC, plus a so-called professional dispense fee, which is supposed to be at least enough to cover the bare minimum cost of dispensing a prescription, that's about $10, plus enough to incentivize the pharmacist to spend the time to counsel the patient. And so in my state, this number is $9.99. In Washington, it's $7. In Missouri, it's like 20 somehow. But what Luke points out is the big lie is that in the commercial, so that's Medicaid. Medicaid pays on a reasonably fair and reasonable market. It kind of breaks down when you're talking about really expensive drugs, where the pharmacy may not have the purchasing power to buy it at NADAC.
Yeah.
It breaks down.
I'll just clarify it. That's just Medicaid fee for service.
Correct. Yeah.
Which, sorry to get into that nerdy niche, but there's states have the option to either do Medicaid fee for service, which is where the government pays directly, or they can do Medicaid managed care, which is where the state pays a premium to an entity, which is usually an entity that also does commercial insurance. And then they own the financial risk for that person. And then they often get to choose whatever the hell reimbursement model they want to set with pharmacies. So this whole NADAC plus professional dispensing fee technically only applies to Medicaid fee for service, which, if I recall, is somewhere around 20 to 30 million people across the country.
It's a big chunk. It matters.
Yeah.
But the big lie is that in the commercial market, we pay pharmacies instead of at their cost plus a $15 markup or $10 markup, we pay pharmacies at the average wholesale price minus most contract terms today with pharmacies and PBMs are on what's called a generic effective rate, where a single claim will be paid at AWP minus 30% or AWP minus 92% or AWP minus 99% plus a 50-cent dispense fee. But in the aggregate, the PBM will target a discount off of AWP of the market today is about AWP minus 86%. And then they'll add like a 30, 40, 5-cent dispense fee, 0-cent dispense fee in some cases. Express Scripts pays $0 as their dispense fee in almost every case. Anyway,
okay, wait. So 50 cent, I keep hearing even the 50 cent is a big.
It's not a typo.
Okay, so we're talking about $10 to $15 versus 50-cent dispense fee.
Right.
Or zero.
Or zero, okay.
Right, so Express Scripts pays nothing for the pharmacist service of dispensing. They pay purely for the product.
Okay.
But they pay more than the product actually costs.
Okay.
Right, so they pay, so where NADAC might be $10, they pay AWP minus $85, or sorry, AWP minus 85%, which might be $15 and the pharmacy makes nothing, or it might be $200 and the pharmacy makes like $180.
It's like a slot machine. You really have no way of knowing until it actually, like, you're running the actual scenario in front of you.
Yeah.
And the PBMs do everything in the aggregate. So they ultimately don't really give a shit if they like pay the pharmacy a huge profit on one prescription or they cause the pharmacy a loss on another prescription. Like, they don't care about each individual prescription. They only do everything in aggregate.
And we haven't even gotten into how do you pay a PBM, but this is where how you pay a PBM matters in terms of what the final price paid by Joe Schmo on the street or Joe Schmo's Crab Shack, who's purchasing these services from the PBM and the pharmacy. But yeah, the big lie though is that pharmacist services are free, and so we're just gonna pretend that the drug cost part is everything. And so where the true price of a medication might be $4, the PBM may pay $1,000 for it. And yeah, that's the big lie though, is that pharmacist services have no value intrinsic to dispensing. It's just all about which pills are in the bottle.
Yeah.
And that causes all sorts of lovely incentives in the market, which I could opine at length on. But
that's what should be taught in pharmacy schools, is that the current reimbursement models, basically everything other than Medicaid fee for service. So that includes commercial, Medicare Part D, it's pretty much everything, and managed Medicaid. Like, the reimbursement models are such that it's exactly what Benjamin just said. The expectation is that the pharmacy is actually paid basically nothing for the service of dispensing the prescription. Their reimbursement, where they're supposed to get all their revenue from, is from the spread between whatever the metric that's being used to tied to the NDC of the product minus whatever their true acquisition cost was. So like, pharmacists are paid nothing for what they do. They're only paid for the difference between how much they bought the drug for and how much they sell it for. And so that system sucks and it creates a million bad incentives like we talked about. So the idea with NADAC is that we wanted to flip that. The goal is that we actually pay the pharmacy as close as we can. We want to reimburse them exactly the cost that they paid to get the drug on the shelf to make it net neutral to the pharmacy. So they basically just get reimbursed for buying the drug in the first place. And then we explicitly give them all of their revenue through service fees. So we're paying them for the service, not for the markup on the product. That's the foundational difference between everything else and Medicaid fee for service. Is, are we paying for the markup of the product or are we paying for the service fee?
What is the historical context behind the lowering of dispensing fees? You'd think if you were a business and you're providing a valuable service like pharmacists do, that you would increase that to make more.
There's so much money to be made. More money on the buy list.
On the markup than the dispensing.
And pharmacy A always thought that they could make a higher markup than pharmacy B could. And they would never talk to each other about how much their markups were. So like basically the PBMs just played all the pharmacies off of each other.
And there's also the context here of the market power. The pharmacy does not have negotiating leverage. Like even the largest pharmacies, Walmart, Walgreens, they have like no negotiating leverage. They have more than I do, but still all of the cards are on the side of the PBM. And so when the PBM presents you with a contract that says that every year they will decrease your contractual AWP discount by 0.5%, and they'll decrease your dispense fee by 5 cents a year, you say, well, it's either accept this contract or walk away from 30% of my revenue.
And I was working at Walgreens when this happened. Like they went out of network with Express Scripts in like, I want to say it was 2013 or something like that. And it was a huge disaster for Walgreens. Like they basically said, screw you, Express Scripts, we're going to leave your network. And then within a matter of months, they basically just came back and said, okay, I'm sorry, we'll take whatever crappy contract you want to give us.
Please, sir, may I have another?
Yeah, right, exactly. So, I mean, that's Walgreens. Walgreens was pwned by Express Scripts. So imagine what, Ben's Pharmacy or Kyle's Pharmacy is going to be able to do. Nothing, so.
There are a few cases, they're rare. There are a few cases where the pharmacy does have contractual leverage. If a pharmacy is in a rural area where there's no other pharmacy within like 30 miles, they have some leverage with that PBM because the PBM needs them more than a pharmacy in the middle of a city, because they need to be able to meet network adequacy requirements with the state insurance department. And so that pharmacy has a little bit of negotiating leverage and therefore can ask for a better rate than any other pharmacy, but they still can't set their own terms. There are cases though where the dispense fee does go up. I read, and this is very much off the record, but I have a copy of CVS's contract with their template contract for 340B covered entities. And they have they have negotiated in their template says that their dispense fee will go up tied to the CPI every year. And so where they're dealing with a 340B covered entity, the pharmacy holds most of the cards, because the 340B covered entity can either contract with them or not. The pharmacy sets the price and says, take it or leave it. And the hospital or clinic can say, okay, forget it, I'll try another pharmacy. But it's about the contractual like leverage that the different parties have. And pharmacies against PBMs have almost no leverage.
Yeah. So Eugene, like that's why it's like basically pharmacies have never had leverage in these contracts, and someone was always willing to take a lower dispensing fee. So, if there's 5 pharmacies and one of them was willing to take the lower dispensing fee because they assumed that they would be able to make a higher markup on the product or whatever, then that hamstrung the other 4 pharmacies. And it basically just became a race to the bottom, since 1995 until now.
Yep. I mean, just for some more historical context here, my uncles and my dad in 97 got together with a bunch of other independent pharmacy owners across the country and held a blackout day where they said, if these reimbursement trends continue, this pharmacy will be closed. And like, this is the 90s when they were making a lot of money compared to today. Like they were making like $20 a prescription above their cost, which is, you talk to any pharmacy owner today and they're like, $8 over my cost is good. And if I can, and I want to get more than that, but like they were consistently making like $20 a prescription and above their cost. And that's just declined every year because of the market forces at play here. And this, I guess also for additional context, Luke talked about how the average pharmacy buys drugs at WAC minus 4% for branded drugs. PBM contracts today are typically at WAC minus 5, 6, 7, 8, 9, 10% for branded drugs, plus a 50-cent markup for dispense fee. TRICARE specifically is at AWP minus 24%, which is WAC minus 9.5%. There is no pharmacy in the country that purchases branded drugs at WAC minus 9.5%. Not even OptumRx mail order buys at WAC minus 9.5%. I have seen their invoices. They buy at WAC minus 8. And so anyway, the whole game now is entirely making money on generic drugs. It's the wholesalers and the pharmacies make all of their money on generic drugs. And the branded drugs they just sell as a loss leader, which is insane because like 70% of the revenue, 70% of the dollars flowing through the pharmacy are the branded drugs and 30% are generics. And that's where they make all of their money.
So when you add all these factors up, you're going to start to see a lot of independent pharmacies just stop dispensing brands entirely. And that's why Kyle is way ahead of the curve on this, because he didn't from the beginning, basically. But like a lot of regular pharmacies, even though they still take insurance, are just going to stop dispensing brands, period, because they don't have any other choice. Like it ties up so much money in your cost, your cash flow, because you have to fork over all this money at the beginning to buy the drug in the first place, and then you don't make any money on it, or you lose money on it later. So it's basically like you're just losing money, period. So you're going to start to see a lot of pharmacies just stop dispensing brands entirely.
Our host that we did our podcast with, Mike Kelzer, he has stopped carrying branded drugs.
Yeah. A lot of independent pharmacies are literally just saying like, hey, I like you, patient or whatever, but for this branded drug, I actually need you to go get this filled at the Walgreens down the street or whatever, because they can't lose money.
And I'd like to, take a different angle on this. And it's not so much about even like the reimbursement mechanism. Our perspective is, if you look at brand versus generic, and which is more along the lines of how Benjamin described what's insurable and what's not, it comes back to the fact that brands, you could argue like Eliquis and a lot of diabetes medications, but as brands becomes, if we look at pipeline, most brands are very either orphan or we could argue over specialty, but they're going to be for a smaller subset of patients, or very expensive, or not first line therapy. So they much more fall under insurable products. So on high cost unknown things, and then not predictable. And so if we look at the future of pharmacy, at least from a Blueberry perspective, we have generics that are bought and sold on an open, transparent marketplace in the community, and brands actually probably make more sense to be a mail order. If you think about how we lower costs on something that's so expensive, one way is to warehouse those, eliminate all the middlemen, and essentially sell directly from the manufacturer and send it directly to the patient who needs it. So it doesn't make sense for 20-some thousand plus pharmacies throughout the country to have one of these high cost brands on hand. So essentially 20,000 copies on hand, whenever there might only be 1,000 patients across the country that actually have that. So even taking it next level up, it's like, why have it at every single wholesaler? Instead, why not just have it at the manufacturers, and then they can send it directly to the patients who need it throughout the country. So that's actually one of the ways to lower cost, and then that would be the insurable market. So you'd actually have those run through insurance and all that. So if we fast forward 10, 20 years or whatever, and have the generic drugs being bought and sold on an open marketplace, brands being direct to consumer, I think we actually have a lot lower cost of healthcare. And so there's actually, beyond just, reimbursement structures, it makes sense for those to be separate markets. It's just, they're so expensive. You're looking at, a traditional retail pharmacy, their inventory is well over $150,000. And they have the exact same generic drugs that we have on hand. And as we know, generics make up almost over 90% of scripts filled. And, our inventory sits at $11,000. So it's a big difference between those two offerings, essentially. So we're currently like in this in between where diabetes medications, and then 26% of America is either has or will have diabetes at some point in their lives. So, that probably should not fall under insurance, but the problem is with rebates and all that that exist, those drugs are ridiculously expensive and, fall in that insurable market right now. But I think in the future they won't, especially as more go generic and things like that. But I think to drive home, and I don't know, to drive home the idea of how messed up the buy low sell high market is, and the dispense fee. Joey, I just sent you an image on LinkedIn. I don't know if you could pull that up.
Okay.
But it's kind of crazy just how reimbursement works.
Just copy it and throw it in this board here. We're not take forever. Okay. You see it?
This is a screenshot of essentially, what a pharmacy submits on the left versus what they're reimbursed on the right. And so for this specific medication, it's essentially, they submitted their base, which is essentially their charge or their usual and customary in this case, equal the same thing.
I walk through this.
Their dispense fee, which is, what's that? Go ahead, Benjamin.
Can I walk through this? Yeah. So the base is they're submitting, that's the price of the medication itself. And then the fee is the pharmacist dispense fee. And then the line below that is those two numbers added together, the subtotal. And then you add tax to that to get the total. And then that is the price that the pharmacy submitted as their charge. Okay, that's on the left. We've got $16.95 plus $9.99 equals $1705.94. That's the pharmacy's charge. Below that, you see their usual and customary is the U and C, $1705.94. Below that, you see three fields that are blank on the left because those are dependent on the PBM. And so then below that, you've got the cost. This is the cost of the pharmacy at invoice. So this is what Luke will see is $24.79. And then the pharmacy gets a rebate from their wholesaler of $15.23. So the true cost to the pharmacy is $9. And so this GP is what the pharmacy would make if they got paid what they asked for. They would make $1,681. That's on the left. On the right, this is what the PBM sent back. So paid, they said, okay, for the drug, we'll pay you $1,130.63. For your pharmacist services, we'll pay you $0.25. Add those together, and we get the $1,130.88. So that's the total amount that the pharmacy is going to collect. below that, we've got the copay. So the patient here pays nothing, so it's a $0 copay. But if the patient did have a copay, you'd say like, say they have a $100 copay, then the next line down would just be $1,130.88 minus $100, so it'd be $1,030.88. In this case, it's 0, so it's just the total and the remit are the same. The remit is how much is going to come from the PBM to the pharmacy as a check later, usually batched with a whole bunch of other claims. And then the cost of the medication, these are all then internal again, cost, rebate, net cost. And so then this gross profit of $1,106.09 is what the pharmacy will make on this claim, assuming that there was no clawback from the insurance. The DIR here of $975.17 this is presumably a Medicare claim. And so the pharmacy is contractually obligated here to accept the so-called generic effective rate, probably, where they accept 11% of the AWP for the drug. We don't actually see the AWP on this picture, but anyway, so the PBM will say, we're going to pay you $1,130 up front, but then they're going to take back $975 of that as an adjustment when they actually cut the check. So the check will say, paid $1,130, adjustment $975, actual amount paid of like 200 some odd dollars, whatever the difference.
140, is that the 146 number down here, the net profit?
No.
Oh, no.
The
Okay, sorry.
146 is what the pharmacy will get after they pay that DIR to the PBM and they pay their wholesaler. So that net profit is after everything's said and done. After the PBM cuts the check to the pharmacy, takes the DIR back from the pharmacy, the pharmacy pays the wholesaler cuts them back the rebate. After everything's said and done, the pharmacy will keep $146 on this prescription.
What is
likely-
that? What
I have
NDC is?
no idea.
No.
I don't know. This is from Kyle.
Yeah, it's duloxetine.
Probably-
So this is what's so messed up. This is what's so messed up. What's that?
It's probably duloxetine 60 milligrams, and it's a specific brand that has a higher AWP than the others. So it's Cymbalta.
Exactly.
Yeah.
Which
This is what's so messed up, and is this would be taxpayers paying that. So patients coming in saying, "Oh, it's only a $0 copay." This is what's going on in the back end. That is basically like, how healthcare is way too expensive. I don't even know how to break it down into my frustrations with this picture, but this picture alone summarizes like everything that's wrong with how we do pharmacy. Because if you look at like, the actual cost of this, which even their net cost is probably higher than what I could buy that at. We probably buy that at, I don't know, $3 for the 180 count, maybe a little higher, I guess. I don't know. But and then add on a $15 dispense fee. Patients probably are like, it's going to be right around $18. But see all that extra money that's being like made and by the PBM. The PBM actually makes that $975 as profit, and the pharmacy makes $146 as profit, and the wholesaler makes $9.56. So it's just kind of crazy to think that all this is needed for a single simple duloxetine prescription
that has an actual cost of like $10.
If I may, that part of the reason why I'm a fan of what we do in Medicaid fee for service is that basically this would just be $24.79 plus $10, and then the state would just pay $34.79, and we'd be done. That's it. So that's how my system works.
Well, yeah, no, I love that system a lot more. But this example, I think that's a pretty high rebate. Like, I don't know if that's like how that compares, Benjamin, for industry average. But what's the stop? And this is a question for Luke. Like, what's the stop for collusion between wholesalers and pharmacies? As we move more towards a NADAC world, of just baking more and more into from a rebate, hiding rebates into costs and so that it's still unknowns.
Chuck Grassley's rebate reform bill.
Yeah, that, or just enough honest pharmacies that don't do that, that would make it obvious if the people that, for the people that are, I don't know. It's a good question. Like we're definitely open to that type of abuse if all the pharmacies start going that route.
I mean, honestly, rebates from wholesaler to pharmacy do not benefit the pharmacy in any way. They could in a world where NADAC was the basis of 90% of claims, but in the world where we live in, the rebates are just a tying mechanism for the wholesaler to be able to monopolize that pharmacy's purchases.
Yeah.
And because you're dependent on purchasing your product from that wholesaler to receive that rebate back. If you don't purchase enough from them, then they'll give you a smaller rebate or no rebate at all. This actually happened to a health system near me who closed all their pharmacies.
Intermountain, right?
Yeah, Intermountain Healthcare had 24 pharmacies throughout the state of Utah until last August, and we hired one of the inside people as a pharmacist from because we wanted to capture some of their patients. So he was in a clinic like a half mile away from us. So we hired him. Anyway, he knows the people that like did all the purchasing, and apparently their prime vendor agreement was with McKesson, and they had bought so much from TopRx and a lot of secondary vendors that they lost every penny of their rebates from McKesson, which meant that the financials of the pharmacy were already upside down and already struggling because they were paying well above market for pharmacist salaries. They were paying most of their pharmacists $73 an hour. This is great for those pharmacists, right? But it's really hard to run pharmacies that are on limited margins if you're paying your pharmacist $73 an hour. And so they closed their pharmacies because they didn't get the rebates, and they were paying above market for pharmacist salaries. And so they just decided to close them all, which is a tragedy for the community, for all of the people that were working there. We suddenly the state of Utah had 75 pharmacists looking for a job one day to the next, and had 230 technicians looking for a job. Like, just all of it, and they announced it like 2 weeks before they closed. So
Just so that you know, we went through our own version of that here locally. It was just called Health Partners. That was two to 3 years ago. It's the exact same situation. Hey, I'm really sorry. I gotta go.
No,
But,
thanks, Luke. I was gonna wrap this up anyway, so I really appreciate
I mean, we
it.
could do it again. I'll just say this, like, we pharmacists as in general, as a profession, like, we've generally ignored all this shit as much as possible. And like, we have to understand how all the money works. Otherwise we're all going to die. So like, pharmacists need to learn how all this money crap works. That's my pitch.
And it's
So,
dense and boring, and you kind of have to have some of these meetings. I need to sit down and digest this stuff, because like, I get it, but I'm sure I'm missing a lot of pieces that you said and I didn't capture. So I want to note that we ran out of space on a text block in Miro, because that was just funny. Like, I had to make the second one because it's like, you have no more characters to describe just the definitions around this stuff. So
Luke, you know
anyway.
what's really funny about that comment specifically about pharmacists needing to know this? Do you know what clinical, I can't think of another clinical position that is in the hospital that has jobs related to procurement in a hospital, that works in a retail setting, that works on the insurance side, that works on the PBM side. You literally have a pharmacist working in every aspect of healthcare. And I feel like the majority of us don't know any of this stuff.
that's the problem.
And I'm the dumbest guy in the room here. I don't know that. I didn't know this stuff before I started talking to you and listening to you all. So I'm learning too.
Well, that's one of the biggest things that I try to drive home with students that rotate through is that we're in a unique position as pharmacists that, you know, we can actually, like, we are one of the few people in healthcare that can actually see costs if we, you know, open our eyes and actually understand it as well. So So to not like, that's one of our, we can argue that, we know drugs better than prescribers, and we do. But also we know costs whenever it comes to those drugs just as much. So one of the big things that's not accounted for in common MTM costs of ROIs and whatnot is, how much can we actually save the patient in this visit is one of the big things with MTM that I'm pretty passionate about. Is so much of it is based on actuarial numbers of hospitalizations prevented or everything on the medical side, but very little is like actually, how can we as pharmacists in this encounter make recommendations to change this patient's costs today, or not so much the patient's cost, but the overall healthcare expenditure cost. But we can't do that currently because we don't teach costs. We don't have direct access to costs. So I think of an example of fenofibrate, where doctor wrote for fenofibrate 50 milligram capsules, and because patient came to Blueberry Pharmacy and they were going to be paying price, they're like, okay, that's 30 count is like, I don't know, $200 or something like that. Let's just call the doctor, get it switched to fenofibrate 54 milligram capsule or tablet, and the patient saves a ton of money. But I think of like in the school setting where we learn about MTM, or in retail practice where patients copay in theory, who knows, doubt if they're the same tier, but what if they were the same tier, those two medications, and so the patient's copay comes out to the same price regardless. We want to intervene in that scenario, and so having access to costs, we can immediately prove a greater ROI, in that exact same encounter, for MTM, for pharmacist services, all of that, and make our case as not just clinical knowledge base, but also fiduciary knowledge base for patients as well. So it's pretty important, and I think to Luke's point, we have to understand it. If we don't know where and how we're making money in health and in pharmacy, if we don't know how pharmacists make the money that they then get paid with, there's no way that we can improve our own situations as pharmacists in the pharmacy profession. So I really appreciate you taking having this today, because I think it's really critical.
Yeah, thank you all for coming and for speaking and giving your expertise. I would love to do this some other time, to keep just talking about this stuff. If you're willing to and want to, I'd love to actually like clean this mess of a Miro board up and like make it understandable in like looking at it, and keep doing that with other topics like that aren't like this with other people, maybe, things like MedRec or something that's super, goes through all these different systems. Just keep adding to this board for different reasons, but focus for now on pricing and whole just supply chain. And we haven't talked about distributing, manufacturers and distribution and stuff. That's a whole different conversation. But yeah, this was a really interesting topic. Thank you again, and hope everybody listening enjoyed. We'll wrap it up here. Benjamin, Luke, Kyle, I'll send this recording to you before we do anything with it, because then just to make sure everybody's comfortable with it going anywhere besides this on my hard drive. So thanks everybody. We'll talk to you later. Have
Thank
a
you.
good rest of your weekend.
Bye.
Bye.